Hello everyone, this is Jessica Veloza, and this is my case study on osteomyelitis. A little bit of history on osteomyelitis. I'm not going to read everything. I've provided far too much information in this PowerPoint, so go back and review it if you're interested in learning more about osteomyelitis. But we have heard about osteomyelitis as far as 250 million years ago. There's evidence of osteomyelitis in reptiles. Hippocrates spoke about osteomyelitis. It was coined abscessus in the medulla back in 1773 by Bromfield. The first professor of surgery at Yale University, Smith, called the disease necrosis, describing death of the bone in 1831, and it was coined osteomyelitis in 1844 by a French physician and surgeon. What is osteomyelitis? Well, it's infection of the bone. It's inflammation or swelling of the bone that is usually the result of an infection. Bone infection can occur for many reasons. It can be caused by bacteremia. It can be caused by an infection from a trauma or a surgery, or it can be caused by things like diabetic foot, vascular issues. So the bone can get infected via a hematogenous route, and infections can be it can seed in the bone from having bacteria in the blood, basically. So hematogenous osteomyelitis occurs more frequently in children. We see it manifest in the long bones usually. In adults, we see it manifest in the vertebrae most commonly. Osteomyelitis variations. Osteomyelitis encompasses a broad spectrum of disease mechanisms with three generally accepted categories: hematogenous or blood-borne spread, contagious contamination, and vascular or neurologic insufficiency associated infection. The characteristics of each category can be summarized as follows. Primary hematogenous spread of bacteria mainly afflicts the metaphysis of skeletally mature patients. That's where I said long bones in kids, vertebrae in adults. Contagious infection is usually from a contaminated site. It's think open fractures, think hip replacements, joint replacements, surgery. Vascular or neurologic insufficiency associated myelitis results from poor blood supply. So we're thinking our diabetics, we're thinking our arterial insufficiency, we're not getting good blood flow. You've seen those black toes, haven't you? So I'm not going to go over all this. This is extra information. I love Hippocrates, but there are different classifications. There's the Cierne Mater, I don't know how to say it. There's 4 anotopic types. This clarifies more than we need to go into. The Bach or batch classification, you see it here. I'm not going over it. It's extra. Here is a picture provided by the Journal of Orthopedics, and it's a diagram for you to see. It just shows places that we commonly see osteomyelitis. It shows an example of those types of osteomyelitis that I just discussed. The primary hematogenous, which is the blood-borne spread. You see an example in A or B, A being that spine, B being those long bones. C and D, you see the contagious bone infection, which is most commonly seen with direct contamination. So we see, you can see it there. You see the hardware. I just thought that was a cool diagram. Here's the picture from the outside. This is not my case study, but this is a picture of a 62-year-old man who suffered an open tibial fracture. So yeah, this is the front of his tibia for 21 years. This is a chronic. So we can see acute osteomyelitis or chronic osteomyelitis. This is an x-ray. You will see the fallen leaf sign referred to in literature. And here's an example of that for you to look at. There are a lot of vocabulary associated with osteomyelitis in radiology plain films that I did not provide details in this PowerPoint about, but you may be interested in looking up for yourself. So not sure if you guys have seen this in real life. A lot of us nurses have and nurse practitioners have. This is that diabetic patient with that chronic toe wound and maybe vascular arterial insufficiency. So this is an amputation of the right hallux secondary to osteomyelitis. Clinical presentation. Acute osteomyelitis is often diagnosed clinically. So we don't always have a very specific way, and a lot of people actually present with, they might just have fever, chills, fatigue, lethargy, or irritability. They might have a localized, like the classic signs of inflammation with the pain, the swelling, the redness. But like this says here, after an acute osteomyelitis infection, if it's becoming chronic, after 5 to 7 days, those signs may go away. So chronic post-traumatic osteomyelitis requires a detailed history. It's not going to present to you like you might expect it to all the time. Weight bearing and function of the involved extremity are typically disturbed. So there's going to be pain, swelling, erythema, and edema. It's very patient specific, guys. Clinical presentation that John Hopkins talks about, some of the same stuff. And like it says, symptoms may vary depending on the cause, whether it's a rapid or slow onset. The following are the most common symptoms of osteomyelitis, like we discussed: fever, pain. Infants who can't express pain may just feel ill or not be acting well, swelling, redness, difficulty moving the joints, a new limp, a stiff back. Symptoms of osteomyelitis may resemble other medical conditions or problems. So, very personalized. This is a list of history and exam. This is a list of risk factors. And here we are at my case study. I chose a very unique case study. It is not a patient I saw. It is a case study that I found because it was very interesting to me. This is a 2-month-old, about to be 3 months. She had a fever and swelling in her right leg and refused to move her right leg for 7 days, right? She's actually presenting to the emergency room, to the hospital. The patient's fever subsided 5 days prior to presenting to the emergency room. During the time that she had fevers, her body temperature was between 99.6 Fahrenheit and 101.3 Fahrenheit for 2 days. However, her right lower extremity continuously swelled. It's red, it's swollen. Parents are bringing her in. This is what it looks like. The baby. Objective information. The patient would cry when someone pulled her leg lower, pulled on her right lower leg. The patient was carried into the hospital by the parents. Through inquiry with the patient's past medical history, they found that the patient was delivered spontaneously and had no genetic diseases. The patient received a TB vaccination. This was not in the United States. This vaccine is not something we commonly do in the United States, but it is CDC website information. It exists. They got that vaccine 10 days prior to being treated with not treated with antibiotics. 10 days prior to presenting. The patient had no history of any other diseases, no sickle cell, no leukemia, no other reason why we should have something going on. Physical exam revealed erythema, redness, and tenderness in that right leg. When you move the knee, she grimaced. Her labs, grossly normal. There's really nothing out of normal here. Her diagnostics, X-ray examination of her tibia revealed poorly defined irregular osteolysis and a moth-eaten pattern. I know I mentioned that fallen leaf pattern. The moth-eaten pattern is another one that you will see. You see it mentioned on the X-ray here, and you see it mentioned on the CT here. Moth-eaten and melting signs of irregular erosions on her tibial metaphysis. This cross-sectional CT showed indistinct borders. So anyways, MRI. So they did X-ray. They went to CT. They went to MRI. There's your pathway. We talk more about diagnostics. I need to move forward faster, but this is a little graph that shows, this is from the AAFP. and it shows, you do a CT, diagnostic imaging studies for osteomyelitis. Differential diagnosis. There are a lot. We could be looking at, and it depends on the patient, of course, but gout, bursitis, sickle cell, avascular necrosis, SAPHO. You see the list here: metastatic bone cancer, older new trauma, infected, like a non-healing fracture, aseptic loosening, or acute hematogenous osteomyelitis or chronic hematogenous osteomyelitis, and those are your ICD-10 codes. And the actual diagnosis is, for her, I'm so sorry, it's actually acute. Well, I guess it's chronic hematogenous osteomyelitis. So we report a case of, this is from the case study. Basically, they don't think they've ever seen a 2-month-old with a osteomyelitis in her tibia like this. They did a lot of research and they could not find any. Yes, it's chronic. I'm sorry for the trip up. Chronic hematogenous osteomyelitis. That's her case study. More information about the case study. Medical history and imaging data led to a diagnosis of chronic osteomyelitis that had transformed from acute osteomyelitis due to delayed therapy. However, the serum like I said before, it's not always going to be straightforward. The inflammatory markers were not straightforward. So anyways, they presented irregular, but basically they ended up having to do a bone biopsy on her. So there's your information. There's your pictures, there's your visual information. So they see this bright red tissue, and they debrided that tissue and some of around the bone, the periosteum, and sent it for biopsy and culture. And after extensive debridement, they sutured it, and the skin did not, and they didn't put any surgical drains. But there you go. That's a picture of, they ended up doing a bone biopsy because all her clinical stuff was not straightforward. So after follow-up, the patient did not receive any IV antibiotics or oral antibiotics. She did not have any fever, the swelling, any more fever, swelling, erythema. Basically, they removed the part of the bone that looked infected. Her labs continue to be normal. Her cultures that were intraoperatively collected were negative, and it took 2 weeks to confirm chronic inflammation, and they did that via histology. So that's, at this point, this is an infectious disease and surgery that's going to be managing this patient, but she had all these unclear signs, and they were able to finally diagnose it with a histological examination performed by 3 institutions. So obviously this was a rare situation. I'm presenting it because I thought it was very interesting. Incision healed well, and at the follow-up, she followed up at a year. At the follow-up at 12 months, the patient had no pain, no limitation on walking, no physical problems, and her x-ray looked normal. So this is the follow-up 1 year after. Okay, so the patient's incision healed well. Everything went good. Labs, we already reviewed what she got. These are the labs: inflammatory markers, white blood cells. You might get a bone biopsy, ultrasound, MRI, CT. You might have to do a nuke med scan, histology. Diagnostics, again, the x-ray. There's some more diagnostic criteria, how to actually diagnose osteomyelitis. Sometimes it will be more straightforward, sometimes it will not. This is just extra information. Again, I'm not going to read through all this. For this patient and for an osteomyelitis patient, an accurate diagnosis is priority. Much of the topic discussed in this presentation is geared more towards like an inpatient setting, right? Family practice setting. We're going to have already consulted out to infectious disease. If there's a chance for us to start some empiric broad spectrum antibiotics, sure. Order some imaging, sure. Maybe we just need to send them to the ER. Patient specific. Treatment's going to be just very patient specific. Clinical recommendations. This is from the AAFP as well. The preferred diagnostic criteria is a positive bacterial culture from a bone biopsy, okay? But we're not always going to do a bone biopsy. MRI is as sensitive and more specific than bone scintigraphy, and it can diagnose. So basically, we do long-term IV antibiotics. This is a sweet little. This is from Hippocrates, and it goes over the history. Just a nice little snippet. Treatment options for acute and chronic will be different. For acute, your treatment options, you're going to give the high-dose antibiotics. They're probably going home with the PICC line and long-term IV antibiotics. Treatment options, again, from Hippocrates, primary and secondary prevention. I'm not going to review that. Here are specific antibiotics, the initial antibiotic treatment for osteomyelitis in adults. It depends on the type of bacteria. So if you can identify it, that is how you make your choices. Again, I'm not going to review this, but there is a very detailed informational about what you would choose based off the different type of bacteria, right? But the duration is generally going to be 4 to 6 weeks of IV antibiotics with an adult. And the bone, in cases where the infected bone is wholly debrided or amputated, you might not mean as much. 2-week course, and then you switch to PO. You might have a wound vac. They might get hyperbaric therapy. So treatment, extra information about treatment. I'm not going to review all of this in detail, but you know, it's very dependent on the situation. I added this for your viewers' pleasure. So review this on your own if you would like to, but a review there, the pathogenesis of osteomyelitis. Bacteria enters the bloodstream, and basically it can manifest itself on the bone. It creates this biofilm, and that continues to form more bacteria, and it just becomes like this colony that is excreting bacteria. And once there's enough organisms on that biofilm, then it matures, and it can manifest into the bone tissue itself. So basically the sensitivity of a culture in the lab, is very important. Staph aureus is the most common. Hematogenous osteomyelitis usually involves I've said that so many times, but I should have made a question about it, but I didn't. Question number 1. Which of the following is not a categorical cause of osteomyelitis? Ding, 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 ding. I'm about to run out of time. But the answer is epidermal contact with toxic substances. The other 3 are categorical causes of osteomyelitis that I reviewed like 6 times. There is your rationale. Which of the following is not a risk factor for developing osteomyelitis? Surgical contamination, contusion with subsequent ecchymosis, intravenous drug misuse, or penetrating injuries. The answer is contusion with subsequent ecchymosis. There's your rationale. There's your reference. Which of the following diagnostic tests is not indicated when assessing a patient for the presence of osteomyelitis? CT, MRI, X-ray, or spinal tap? Spinal tap is the answer. The other 3 are indicated. Number 4, a patient comes into the hospital complaining of a fever as well as pain, swelling, and redness in their forearm. While examining the patient, a doctor takes a blood sample and notices that the white blood cell count is high. If the doctor suspects a bone infection, then what should the next step in treatment be and why? Take a bone biopsy, perform an MRI, prescribe antibiotics, or do an amputation to get rid of the infection. This one was tricky to me. I wanted to say B. I wanted to say MRI, but I actually got this one from study.com, and what their argument was that you're going to perform an MRI, but you might have to wait on that MRI. So basically after, you will do your blood cultures first, but you need to go ahead and prescribe antibiotics to fight that infection. You're going to get that MRI. Hopefully it'll be simultaneous, but it may not. And here are my references, and that is the end. Sorry I had to talk so fast. Thank you guys for your time. Review this on your own if you want more information. Sorry if there's duplicate information. Have a good day. Bye. Thank you.